Really. And thank you, Colleen, for joining us today, and everybody who's joining both in person and online. Really excited to welcome you back. I can say that. Dr. Colleen Barco is a professor emeritus with the School of Nursing after a long career focused on addressing issues of structural violence related to substance use, various communities across healthcare systems, a mentor to many people here, probably online, and I know in the room. And so really thankful that you've joined us today and share the work that you're sharing around addressing substance use across care settings and providing resources to inform teaching and practice. So I'll hand it over to you.
Thank you. Thanks, Emily. I especially appreciate that coming from you. Nancy, would you like to introduce yourself? Nancy's our research manager. Can say a little bit about you?
Sure. Yes, it's great to be with everyone today in person and virtually. I'm a research project manager with Colleen and the Equip team. I use she, her pronouns, and I'm really excited to connect today about these topics.
So, sorry about the technology, folks, and welcome to people online. We are going to try to convince you to use some of our resources, which are bought and paid for by the Canadian taxpayers today. So can you, let's go next. Yeah, thank you. And before we start, let's like to do a land acknowledgement and acknowledge that we are on Musqueam territory here at UBC. I normally live on the Shishal territory, and our program of research is really dedicated to anti-colonial work and trying to be in service to Indigenous people everywhere as much as we can. So, you know, we wanted to just acknowledge that I'm going to be talking about violence and substance use. And even in your working, if you're working in these areas every single day, it still makes you think when we're talking about it. It makes you think about what you've seen, what you've experienced, or about other suffering. And so just, you know, if you need to go get a glass of water, go get a glass of water and just participate as you like. So thanks. So what we were hoping to do is talk about this idea of substance use health and a different approach to substance use than perhaps has been in the past. And we want to highlight the interrelationships between trauma, violence, and substance use, and then put as many resources in your hands as we can possibly do. And we're hoping that this will help in your teaching or in your research, however you are engaging with people in policy that you're developing, whatever you're doing. So we're going to give you a little bit of a background and an evidence base. I'm not going to spend a lot of time on the research behind all of this, but it's widely available, and then really focus on sharing resources that we're hoping you can use in your work in some way. We're going to show you an animation. We're going to show you some language tools. We'll have QR codes for those that are online so that you can get them, and they're all available on our website. And then we're going to, we were going to try to play a game, but it seemed too complicated to actually fully play it. So we're gonna partially play it and try to engage you, just to show you how the game would work and what it's good for. And then we'll finish up just mentioning a safety planning tool that is still to some extent in process, and have a conversation with you, hopefully. So next, thanks. So this is just, some of you have seen this before. This is just 2 programs of research that I've been involved in, really focusing on violence at the interpersonal level and then violence at the structural level. So at the interpersonal level, we have created a program, a nurse-delivered, woman-led program. Kelsey Lynch was a manager for, that is very, very effective. We've had RCTs and shown that the impact on women is profound, and it not only reduces trauma symptoms, depression, improves quality of life, but also very interesting, first study to do it that we know of, reduces the severity of violence to which women are exposed, which is, you know, is phenomenal. It wasn't one of our intended outcomes. So we've also we built it over 3 decades, and we've also created an app. You have the QR code there for the app, and these little cards say nothing. They just have a QR code. They're kind of safe. And it's an app that supports women in not just finding resources, but learning things. So learning how to manage stress better, learning how to manage chronic pain, learning about the policies or the legislation in their particular province related to child maltreatment or child protection and what the policies are. So like just as examples, and connecting them to resources. So that's available. Then we have a whole other series of studies that is focused on equity, and we're trying to support healthcare providers at the organizational level to promote equity. So we've tried to tailor it to many different contexts. We've did a number of studies in primary care settings, in emergency departments, in cancer care settings, and then we've most recently really focused on this idea of substance use health. So, please. So what we think that equity requires cultural safety. Probably no one would have a question about that. But that it also requires trauma and violence informed care. And this is what I'm wanting to argue with everybody today, is that most, if a high proportion, if not most, of your patients, whatever context you're in, or the people you're serving, will have been exposed to trauma and or violence of some form. And so, you know, I think all nursing practice, all healthcare practice should be trauma and violence informed. But you can't have trauma and violence informed care without cultural safety and vice versa. And we argue we cannot have equity unless we take a much more trauma and violence informed, culturally safe approach to substance use. So currently the levels of substance use stigma are really preventing people from getting care and contributing to the high numbers of people that are dying and at risk. So we think any door is the right door to come in. Doesn't matter where you start, but you need all of these things. And what we've been trying to do is really emphasize all the quintuple aims of healthcare improvement. So not just aiming at the usual, which is lowering the costs of care, efficiency, but also aiming at the care experience of, first of all, the people we're serving, and secondly, the providers. So the well-being of the workforce. So we're always trying to keep that in mind at the same time as we're working on improving health outcomes and also improving efficiency. So next one, please. So we're just showing that, you know, normally a lot of our healthcare policies are really aimed at efficiency, not necessarily simultaneously taking all the aspects into account. Next one. So I'm just going to say a little bit about this idea of substance use health. I can't see hands for people that are on Zoom, but so I don't know whether most of you have heard of the concept of substance use health. Have you heard of that idea?
Yes, and we use
from me.
but we also use the same framework.
Okay,
Yeah.
excellent. Okay, I'm so happy to hear that. Yeah, so our colleagues at CAPSA created this idea of substance use health as a non-stigmatizing approach to substance use that tries to really treat substance use across the spectrum and really support people to have the optimal health, as much health as they can, regardless of their substance use. And so we really like it because it gets away from abstinence only. And when you work in the area of violence, specifically violence against women, there's all kinds of policies such as, well, you have to not be drinking or you have to not be using in order to access a shelter. which doesn't make any sense given the relationship between trauma and violence and substance use. So we also think that it supports this idea of shifting away from a disease model to thinking about substance use as something that is learned and that different things can be learned. So we particularly emphasize the importance of engaging people with lived expertise, and we think that that is fundamental to any equity. So I think Sham's example of working with a youth advisory, for example, in your dissertation work, is an example of that. You have to have the lived experience of the people that you're trying to best serve if you're going to actually do the best job you can, right? So I think this is really important, that a lot of times when we say substance use, we think about people who are on the end of the spectrum where their health is most affected, and we're thinking about people who would be diagnosed with substance use disorder, and we're often thinking about illegal use, but that's what we're trying to shift away from. So next slide, please. So I just want to, I'm not talking about violence, but I am talking about the fact that high proportions of people in Canada and elsewhere, of course, have experienced violence of some form, and that the majority of people in Canada use some kind of legal psychoactive substance. And I think this is really important because we tend to think, when we hear substance use and we think about the drug toxicity crisis, we think about illegal drugs or unregulated drugs. But really, we should be thinking about the fact that the majority of people that we're serving will have been using or will have used a psychoactive substance. So you look at those numbers: 79% alcohol last 12 months, 32% cannabis, et cetera, and 13% of each of opioids, sedatives, cigarettes in the last 12 months. So I think that, like, trying to really focus on the impacts of legal substances as much as we focus on unregulated substances is important. And I just threw up a couple of examples of the forms of violence that we know people experience. You know, we haven't improved things, because when I started doing research in this area, it was 33% of women over the age of 15 had experienced intimate partner violence sometime in their lifetime, and now we're up to 44%. So, you know, every client that we're interacting with has a high likelihood of A, using some kind of substance, and B, having experienced some form of violence or trauma. So this should be throughout all our work. Next, please. We're just going to share with you a brief animation that we're hoping people will use widely. I think it's about 4 minutes long, and we'll have a little chat after that in terms of. You have to turn down the volume, turn up the volume, mute.
Imagine a woman, let's call her Anna. Anna has decided to get help after years of abuse from her partner.
Sorry.
Lately, she's been using alcohol and opioids to help with the overwhelming pain and fear she feels. Anna thinks she needs to leave her partner to be safe, but she also knows there are risks that come with leaving. She's terrified about what will happen to her children. Anna is ashamed for having stayed so long. And for using substances to make it through the day. Cut off from family and friends and a community of care, she feels lost and unsure. How can we best support Anna? The relationships between gender-based violence and substance use are complex. Some people use substances as an excuse for using violence or to control their partner. Many people, like Anna, use substances to help deal with the impacts of violence, but we often blame them when they do. How we think and talk about violence and substance use impacts how we care for people. When violence is seen as the uncommon actions of a few people, we overlook how being abused or controlled because of your gender is part of everyday life for many people. When we dehumanize people who use violence, we overlook that many experienced violence themselves, and we close the door to real change. If we view substance use as a personal moral issue, we might support misconceptions like substance use causes violence, it excuses violence, and even that people who use substances deserve abuse. These ideas lead to stigma and shame and prevent people from seeking help. And when they're excluded from services, the consequences are serious. Together, we can imagine a better future. What if services were based on understanding that many people use substances to manage and reduce the emotional, spiritual, and physical pain arising from trauma? What about seeing substance use as a spectrum with a range of risks and benefits? What if we assumed that a person who uses violence might also have experienced violence? We could even have conversations about substance use health in the same way we talk about physical and mental health. There are so many encouraging possibilities, and it's up to us to collectively transform how health and social services are offered. Consider how trauma and violence-informed care can guide services by putting safety, trust, and choice first, using strengths-based approaches, always with the focus on ending all forms of discrimination. What if we started by recognizing the strengths of people who have survived violence and followed their lead? Meaningful support happens when you meet people where they are, with information, workable options, and realistic choices, including about their relationships and substance use. Trying to control people's decisions will drive them away from services, and having expectations of outcomes will keep them from coming back. Collaboration is key. To make sure policies and practices address the relationships between gender-based violence and substance use, people with expertise about violence, substance use health, and the law are all important. People with lived experience of both gender-based violence and substance use stigma are needed to provide direction. Effective services will recognize that many people experiencing violence may turn to substances to survive overwhelming experiences, often at the cost of their safety and health. We can use language, policies, and practices intentionally to make services safe and welcoming for everyone, regardless of the nature of their substance use. This includes staff who will have diverse experiences and understandings of violence and substance use. When we put people at the heart of every service and every interaction, we open the door for real connection and meaningful change. Through systems change, community collaboration, small shifts, and step-by-step progress, we can create new approaches and pathways so that people like Anna can find support, safety, and well-being. For more resources to support substance use health for people experiencing gender-based violence, please visit equiphealthcare.ca.
So any responses? Can you see the chat there, Marilee? Oh, thanks. Anybody respond? What do you think?
I thought it was great. I liked that it was, a digestible amount of time, but covered a lot of terrain. And I think really helpful for those of us who are, either, as you say, teaching or practicing across different settings. And I'd really love to see it incorporated in things that aren't specific to, a mental health setting, for example, where we often co-locate this type of content. Yeah.
Oh, thank you. Yeah.
Do you know where other types of teaching settings where it has been taken up beyond?
We just released it not very long ago, and we can see that it's being downloaded, but we don't know necessarily where it's being used. But
And the
Yeah.
prompts.
So thank you, Colleen, for sharing. I have a couple of comments. I love it, and for a couple of reasons. The first, I'm very rarely to see like a person who look like a Muslim within a video or media, and I feel like this is one of the rare incidences. So I'm so thrilled. Yeah, because that's an active representation of collaboration, and like hijabi Muslims or people who come diverse backgrounds, they actually part of this community and they go through similar challenging experiences. Although maybe as a person also I come from a diverse background, the concept of substance use potentially can be different from the rest of the people in the image. But we all talk about the same thing, a substance that may lead to violence or trigger violence and trauma related to trauma, past or present. So yeah, thanks for sharing. I'm surprised in a good way. Yeah, thank you.
Great, thank you. Well, it's a fine line to walk between not stigmatizing
Mhm.
and being inclusive. You know, it was really, really hard. We right down to the wire, we're working on skin tones and stuff like that because we want to hit the right message. So it's really important. And we worked with the Muslim Resource Center in London, Ontario, and they actually say that, you know, a lot of times people are assumed that they might not have any substance use problems because the culture is so strong. And so there's a lot of negative, you know, assumptions made that people don't need support. So thank you. Was there anything on the chat?
Yeah, very positive comments online too. Comments like very powerful, wow, impressive to capture so much insight in such an accessible piece.
Great, well, thank you. Please use it in any way, any place that you can. Next, what we were trying to get at here, and I don't know to what extent it comes across, but we're really trying to push back on assumptions. The assumption that substance use causes violence. It doesn't cause violence. And that it's often used as an excuse. And I don't just mean at the individual level. I mean in policies, in court cases and so on, where substance use is used as a rationale for excusing violence. So we're trying to push back on that. We're trying to push back on the fact that there are complex relationships to between substance use and violence. And they're not simple. It's not simply a matter that a person consuming substances therefore might be more violent. That's an oversimplification that we're trying to get beyond. Next, where are we at? Okay, just one more thing to say, and that is you'll see that in that we were trying to emphasize pain as the center of substance use, that when people are using substances to an extent that it's harming their health, often it's to deal with pain, whether it's physical pain or emotional, mental pain, right? And I've been really excited about the shift in understanding, my shift in understanding about suicidality. When you start thinking of it as suicidal ideation as an effort to deal with unbearable pain, it really shifts your thinking. And my brother committed suicide when he was, or died by suicide is the new language, died by suicide when he was 18. And so I have not been able to even think about suicide for years and years and years. And now I can, because I have a new understanding of it. So we have a whole whack of resources also related to suicidality if people are teaching in any space where that would be relevant. So, and that I would say that would be most spaces. Okay, so we're just going to run through just to give you a couple of examples of resources that we have, and then we're going to show you a couple more in detail. So the first one, I just want to let you know there's these little things are available. They were a response to the fact that in our emergency studies, we ran into the issue of how do you put 800 staff at Surrey Memorial Hospital through some kind of equity training. It was just cost prohibitive, but these take 5 minutes, about 4, 5, 6 minutes, depending. And each one has got the top 10 things or the top 5 things that every healthcare provider should know about whatever the topic is. And it's got a little video clip of somebody with lived expertise talking about it. So any of these topics, it's just a quick way of giving what you called, Emily, a digestible chunk. So, yeah. Next. We also have something bigger. We have a whole course free online. You could swap it in for like e-learning if you want. And because there's a certificate at the end of it so that teachers or professors can know that that the students have actually gone through and completed the quizzes and stuff. And it focuses on these intersections. So really trying to put forward the interrelationships between chronic pain, trauma, violence, and substance use. So this is just giving a little snapshot of just one of the modules within this course. Just gives you a little flavor for what it looks like. It's lots of videos, interactive stuff. There's a case study at the end that focuses on pain management. Okay, so now we have, oh no, we don't have a copy of this one. This one is in process. It's a safety planning tool. So it's a tool that provides providers with some ideas about what common substances are, what they look like, what looks like when people are using those substances. It gives you a little bit of background, and then it has a template for planning. Next. We have this just blown up a little bit. So it's just a guideline for talking to folks depending on your setting. And this one was developed for the gender-based violence sector. So you see there's lots of stuff in there that is only appropriate if you're in a residential type context. So this is kind of what the gender-based violence sector wanted or found useful, and we've tested it with them, but we're developing a version for a more acute care episodic setting. So in an emergency department or primary care setting or that kind of thing. So yeah, so I'm just pointing you to things that are totally available and online, and help yourself. And then we'll come to our language prompter. So people who are in the room have a copy, and folks online can look at it by using the QR code. And what you'll see is it's a 4-page thing that, as you can see, gives you some background to some guiding principles, some language shifts. So don't say this, say that. We started doing this when a physician in Prince George, who was responsible for the Northern Medical Program, said, I'm having so much trouble teaching the residents just how to talk to people. And she said, I want some cards that say, don't say this, say this. And so I thought it was a bit insulting, but we made them up and they seem to work. And, instead of saying, do you drink? Don't ever say, do you drink? Say, do you drink alcohol? If a person says no, then leave it alone. If they say yes, then you can go on to ask more detailed questions. So just as an example. So we have, language shifts. We have a few considerations, and, Shams, to your point, we have tried to, in our don't assume, we've tried to address exactly what we were talking about before. And then finally, as I said, it has some sort of principles for putting your language into action. So we have that, and that we have now incorporated into a game. So we also have a single sheet that just has the don't say this, say that. And we're going to show you our game now. And Nancy, you're going to start that, aren't you?
So as part of our process working with community-based partners, we heard that folks were interested in resources to apply these learnings about the intersections of gender-based violence and substance use and stigma, but perhaps in a more engaging way than a paper-based format. So we took a journey with them and we've actually created an educational game. It was our first foray into game design, but we got lots of support from folks with varied expertise, folks from CAPSA, folks working in the community and gender-based violence support, and also a game designer. And so what we've come up with and are soon to release is a game called Glimmers. So you can see a picture here of what the cards look like. So it is a card-based game in which players introduce a scene related to gender-based violence, substance use, and stigma. And they use the card to introduce that scene using sort of neutral, sometimes stigmatizing language to introduce that scene. And then everyone in the group listens for the glimmers. So glimmers are sparks of joy, assets, strengths. You can think of them in comparison to triggers, for example. And then they reintroduce this scene using the glimmers the group identifies. So really what it's getting at is learning more about the intersections of gender-based violence, substance use, and stigma, and trauma, and violence. And in particular, it's about practicing a strength-based approach and a strengths-based narrative and being able to see what might be sometimes hidden strengths or glimmers. So we've told you a bit about it. But now to bring it to life, we're going to do a little bit of a round with you so you can get a real sense of what the game is like. So what we're going to do is that Colleen is going to play around. And what we're going to try today, and we'll see how that works in a hybrid space, is that we're going to ask you to all listen in when Colleen introduces this scene and try and think of the glimmers, the strengths, the assets, sparks of joy that come to mind. And then you're going to write one into the chat, or we'll give you a piece of paper here. And then what's going to happen after that is Colleen is going to remove any duplicate responses. And why do we do that?
We do it because you have to be creative. And if you play this with real people, you get crossed out all the time, you really stretch your brain to actually see something beyond the obvious. So.
Exactly. And so after Colleen removes the duplicates, she will use these glimmers to reintroduce the scene card she has. And then everyone claps and we go around taking turns. But today we'll just give this demo round a go. So I'll pass a card over to Colleen.
I've never done this one before. So, okay. Hi, I'm Maria. I'm 26 years old. If you believe that, I've got some swamp land in Florida for you. Okay. Sorry, back into character. You can read this, just read the facts, or you can actually be somebody. So I'm Colleen. I'm 26 years old. I have 2 children. They're in care right now. I use stimulants a lot, and but I have just left my abusive boyfriend. I'm fighting with my mom quite a bit. She doesn't want to care for the kids. And I've asked my dad for help, but he's kind of hemming and hawing. So I've been just couch surfing. I've been staying at friends' place, and really what I just want my kids to love me.
All right, so we welcome you to put a glimmer into the chat or write one down. And then Colleen will take a look at these glimmers and try and reintroduce the scene.
Don't give me too many.
Just one is great, the last one. She's going to have to put up a strength.
Yeah.
And really our hope here is just to give you a sense of what the game is like. We have play tested it in a variety of settings and just really pleased to see that people understood the game. There was laughter, there was clapping, and so we're excited to launch soon.
We have a couple online too, if you want.
Okay, a couple online. Give them to me.
One is I love my kids. One is just left an abusive relationship. And one is she's willing to talk. She's here. Another one is just trying to do her best to find a safe place for her kids.
Thanks for those. And Colleen is writing these down and collecting responses from the room here.
And we've done this with groups of up to 60, and it's amazing. People get it. They get it. They can do it with only the instructions we gave you. And hopefully I'm going to show you how it works. But okay, so I'm going to take out. I've got a couple of left abusive boyfriend. Got 2 of those, 3 of those. Okay. And I'm gonna. Okay, I've got a lot of very diverse things. I gotta remember them all. Okay. Hi, what was my name? Maria. My Starbucks name. Hi, I'm Maria. I'm 26 years old. I have 2 young kids in care. I'm using a lot of stimulants, but I'm here and I'm looking for help, and I'm ready to talk about it. You know, I'm having a rough time with my mom right now, but I have a relationship with my parents. We've kept in contact, and I've asked my dad for some help. We'll see how that goes. You know, and to this point, I've been relying on my friends. I have quite a few good friends that are letting me stay at their place. And really, I really love my kids. I want them to feel good about me. I'm trying to find a safe space for them to live. And yeah, I really want to be loved by them, but I want them to be safe too. Okay, so what is amazing to us, surprising to us, is that people just get into it, and they say, oh, we don't like role playing. We say, don't have to role play, just read the card. And then they get into role playing. When you tell them they don't have to, they do it. And then they fall off their chairs laughing and clapping. It's been amazing. We've done it at a couple of in-person conferences. We have a version that does work online, but we didn't know how to mix them. So this was our best attempt. So
Well done, Colleen. So a few other notes I would share about the game. So one is what you heard today is what we call a client scene card or a person coming for services, but there are a variety of different cards. So there are cards about service providers, about clinics, about policies, about places in the community. So it's an opportunity to try talking using a strengths-based narrative approach around a variety of different scenes and scenarios.
yeah, and I would add a couple of things. One, there's red words on here. I was supposed to change abusive to something else, a person who's using my partner who's violent towards me, or, you know, shift it up, and we've got guidance on how to do that on the little language thing. The other thing I just wanted to mention, I used it with the training nurses who are working with women experiencing violence, our IHEAL nurses. And what they said at the end of it was, you keep telling us to use a strengths-based approach, but we didn't really know what that was. And now we know what that is. And so they found it useful to practice, because when you go around the room, different people get to practice different things, and you get to hear different strategies. Yeah.
Thanks so much, everyone, for trying around with us.
Yeah. So did we have one more? Well, we won't do that. Well, we can do that anytime. Do this one, please. Just go ahead. We have no technical difficulties. But what are people's thoughts about the game or any of the resources that we've shared? Anything online there, Marilee?
Just give them a second.
We'll give them a minute. Yeah, go ahead, folks that are online. Anything? Shams?
From the one round, based on my simple experience, so the game is designed in an open approach, which actually triggers dialogue and like I did not sense that I have to actually answer in a certain way or like follow, I don't know, X and Y and Z. But actually it's very open and it depends on my own reflection, and it's also based on my building my own strength and abilities and understanding of each case, and it's fun.
People do have fun. Like I tell you, I was so nervous when the people asked us to make a game. I was like, a game about violence. Yeah, that sounds good. I was quite nervous about it, and yet people are able to do it and have fun, but about a serious topic, and it really did surprise us. Yeah. But we had to learn about game mechanisms. Like how do you shift a game just by, you can add points. You can actually make this a game where there's points. You can make it into a teams game. We have not a version, but we have blank cards. So when we went to the cancer care setting, we said these cards probably won't apply to you, but you'll get the sense of the game, and then let's make up your own scenarios. At the end of it, though, they said these cards totally work. They totally work for us, and so we didn't expect that. We thought they would need to make new contexts and new kinds of games. So yeah.
You really picked up on some of the tensions of game design that we learned about. So if you want a game to be fun, there has to be a certain amount of openness. You can't be telling people this is all the information we want you to know. And there has to be some kind of tension built into the game. So we really worked with that. How do we create something that provides a safe space that is educational, informative, and builds strength, but also it feels like a game and is fun and embodied. And so I really appreciate you picking up on those pieces.
You're welcome.
We have an online comment too. Love these tools and we'll use the game for sure. And we'll add these new ones. Excellent work. And then this next one just came in.
Oh, I can see. Elena Steinberg.
Just a more general question. How should healthcare providers approach patients with severe substance use disorders whose ongoing prolonged substance use appears to impair their ability to understand, appreciate, or engage in decision-making about their medical conditions and treatment options? Often I have difficulty assessing the person behind the substance user or accessing the person, sorry.
Well, that's a really simple question with really simple answers. Yeah, that's really difficult. I mean, I would say compassion is so important to put in the foreground. And what we found is, and this is, I don't know how to say this without sounding just terrible, but you know, when people have been so downtrodden and stigmatized and then are shown not a little, but some compassion, it's just amazing what that can do for folks. I'm going to invite Emily to see if she has some comments to this question as well. But I think when somebody is so unhealthy because of their substance use, it is very difficult, especially when you're worried about their ability to consent. And we've run into this in a number of places. Like, for example, when we were collecting data in emergency departments, we would have people who, you know, on admission absolutely could not consent to participate in our research, is what we were looking for. And we just keep going back and going back and going back. And, you know, 24 hours later, folks could participate. So I just think it's so much patience and so much compassion. I know that's not a very satisfactory answer. Emily, what would you add? You have experience in this.
Yeah, I think what has always been helpful when I've been working in those types of settings is to park the assumptions and to create time to build relationship. And again, like you say, it doesn't take a whole lot. I think a very little can go a very long way. And one of the practices that I would typically incorporate was to have curiosity and ask people about their experiences and to tell me about, the story of, whatever reason brought them into this care interaction. And often I would get, an initial response about, you can read the chart kind of thing. And my response back is, I can and I have, and I want your story because that's been already filtered through somebody else's lens. And that often just created an opportunity for somebody to say, oh, well, you care about what I have to say as opposed to just, how I've been painted by other people. And then I would get a story that may or may not align with, what the narrative about them had become. And just those efforts to really show up as a human being with another human being, I think can help to break down some of those walls.
Nice. And Emily, it's more what you showed was more than just park the assumptions. You were pushing back on assumptions. And, I think each of us has to do it in our own language. I do things like I say, people don't smoke for no reason. Or whatever's going on, that's, I never forget this one man. I mean, this isn't directly about substance use, but it kind of is. And I asked this man how long he'd been in the downtown east side. And he said, oh, I came here in whatever year he named, and he was 14 or 13 at the time. And I said, you were 13. And I said, oh, well, he said, yeah, I ran away from home. And I said, well, little boys don't run away from home for no reason. And it was just like this, then there was this gush. And this man was he was somebody that you might look at and be afraid of, right? And so he just had this big gush. So I think that, as Emily said, patience, pushing back on assumptions, compassion, and just persistence can ultimately unlock a lot of potential, I think. Yeah. Were you going to say something?
Yeah. So taking into account what you have shared before the game, the pain, being able as a healthcare provider to understand their pain and value that experience. And I can totally relate to what you have shared about like smoking cigarettes or smoking and going through a trauma or pain. And why I can relate, like I can use my dad as an example. Like he was a heavy smoker, and then he lost his dad, and then he said, okay, I need to quit. But then my family now are going through trauma. Like my brother became disabled because of an accident, and he is his only son. And since the day he saw his son, he smokes like 3 packs per day. And and he knows like how I feel about smoking, but I don't even show him any sign of negativity. And that's how I kept that positive bond with it. At least he listens to me whenever I try to work on the other health related challenges. But I feel what kept me connected with him or many of my community when it comes to substance use is not only showing compassion, because like nurses, we care, but actually having that ability to understand. It's not people actually, they sleep and they wake up on the next day, okay, I want to smoke like 3 packs a day. There is something behind it. And I assure you, Colleen, and I'm not talking about Canada, like across the globe, majority of the time, a healthcare provider don't see that. And they don't understand actually there are other contextual contributing factors to substance use, environmental factors that build generations to use substances. I think if we as a healthcare provider just focused on pain, understand there is a reason, and we need to work on it, and we need to address it, and maybe refer people to resources to address the pain. Pain will not disappear in a month or in a year. It will take people years to overcome it, which means that I have to, as a healthcare provider, acknowledge that my client could use substances for years. and I should be there for them, not to judge them. And I speak from my culture because there is so much negativity around smoking or using substances like or alcohol. But being that persistent and not to lose hope in them, this will bring them back.
Yeah, I mean, I couldn't say it better. Thank you. And I just wanted to mention that, in our research with women, Indigenous women using, who've experienced violence, and we don't tell the women what they should or shouldn't do. And we don't make substance use reduction a goal. That's not our goal.
Yeah.
Just whatever the woman's goal is. And what is very interesting is, number one, women do reduce their substances when they're well supported and treated with non-judgmental compassion and positive regard. And the other thing is that in our research, those are not published yet, coming soon. Those are the women that actually benefited the most. So